consulting firm. We offer fiduciary support, fee benchmarking, investment analysis, target date fund consulting, and plan design assessments to enhance participant retirement outcomes. Today's webinar is being presented by our partner, Ron Bezos, who is a Director, Retirement Investment Consultant from John Hancock Investment Management. Now I'd like to turn it over to Ron.
Thanks, Rita. Appreciate you having me here today. Good afternoon, everyone. Thanks so much for joining our session on understanding Medicare. Like Rita mentioned, my name is Ron Bezos, and I am with John Hancock Investments. And again, we want to thank you for joining this really important topic. And as most of you know, retirees are faced with many topics that they need to know about these days, but some topics are more important than others, such as really understanding Medicare and the impact it can have on your long-term financial plans. I think that by better understanding Medicare, you can not only better prepare for future healthcare costs, but you can also help to avoid making mistakes as you're going to go through that process. So that really brings us to our goals for today's discussion, which are twofold. First one, of course, is for everyone on today's call to walk away with an enhanced understanding of the Medicare system and how it works and how it operates. And then the second goal, which is definitely the bigger one for me, is to try to do so in a way that's not going to put all of you to sleep after you've worked all day, because the Medicare content is known to be a bit on the dry side. So, really my goal today is to present this material in a way that's going to keep everyone engaged and entertained as we go through it. So with that, let's dive right into the presentation. And as you see this couple here on the screen before you, there's a few things that might jump out at you. It could be looks of, utter confusion, being lost, trying to connect the dots, etc. I can tell you why that is. It's because this couple is turning 65 years old this year, which means they're eligible to receive Medicare. And they're trying to figure out what in the world is going on with it, because the last 6 months, they've been getting inundated in the mail, right? A whole big stack of paperwork. They're trying to read through it all, trying to make sense. And as they're trying to do that, it's like the telephone keeps ringing with telemarketers trying to sell them some form of a Medicare Advantage plan. And then when they want to take a break and walk away from it all, they turn on the TV. We're in Medicare commercial season now. It's like commercial after commercial with people like George Foreman and Joe Namath talking about how great their Medicare Advantage plans are. And it is a lot. It's daunting. It's confusing. And we ask, is this how Medicare makes you feel? Because it's what we find how it makes most Americans feel. It's confusing. They did not make it easy on this. But the good news is that we're here today to break it all down, talk through it all. And I think the best way for us to do that is by following the agenda that you see here on the screen before you. And I think it's important to quickly take a step back before we take a step forward and really just talk about the history of Medicare so we can just wrap our heads around how large scale this really is. After we do that, we're going to talk about the different parts of Medicare and what enrollment looks like to all of you. And then following that, we're going to take a look at what it might cost you on a monthly basis so you can begin to plan and prepare for that future cost. Following that, we're definitely going to allocate some time in doing a comparison of Medigap plans versus the Medicare Advantage plans. And then we're going to wrap up by talking about working past age 65, which is a very hot topic. I get asked that very often. I'm sure it's on a lot of your minds as well. So we're certainly going to give some time to talk about that. So let's begin with the history of Medicare. And as you can see here on the screen before you, the big day was back in July 30th, 1965. President Johnson signed Medicare as we know it today into law. Now, this was such a big deal because at that time, there was really no next step. There was really no next step for folks who were on group benefits, retired, and there was nothing for them to go into. There was no standardized form of healthcare for them to go into. So really only about 50% of retirees had an actual form of healthcare. And to make matters worse, we saw about 8 million seniors living in poverty because they couldn't afford their medical bills. I mean, how heartbreaking is that as you had folks work their whole lives to now retire and go in their golden years and they're struggling to get by because of healthcare and all of that. I mean, this was a big deal. And several presidents prior to Johnson unsuccessfully, tried to get something passed through Congress. Really started with Roosevelt. JFK, he tried to unsuccessfully. Then you can see here in the middle of your screen, President Truman really worked to get something passed, which is why when President Johnson was able to do so, he wanted to honor those efforts, gave him and his wife cards 1 and 2. And then we saw 19 million Americans enroll in Medicare. All right, well, that was then. Today, we see about 65 million Americans enrolled in this. And many economists are saying that by 2030, there's going to be about 75 million Americans enrolled in Medicare, and it's going to be about 15 to 20% of the U.S. budget. Now, think of how gigantic the U.S. budget is. Think of how huge 15 to 20% of that would be, right? Think of all the things as a country we spend money on, like the COVID relief, like the Ukraine war, right? All this kind of stuff. So the fact that we're talking about this big of a dollar amount, I think is really important for us to, just again, wrap our heads around how large scale this really is. So moving on from the history, we're going to begin with what I call it the Boston accent slide. Of course, I'm from the Boston area. If you don't know from my accent, this slide will make it brutally honest, where we'll say Medicare starts with the parts, and with that, there's only 4 parts of Medicare. I'm sure all of you have heard of that. It's A, B, C, and D, and we're going to talk about each one. We're going to start with Part A. So when you hear Medicare Part A, that is going to be your inpatient overnight hospital stay. Okay, it's going to cover also any sort of skilled nursing you might receive up to 100 days, any sort of blood transfusion or medication we get in a hospital, that falls under Part A, and hospice care as well. So we think about Part A as being our room and board in the walls of a hospital. Now, shifting over to Part B, that's going to be your outpatient coverage. Okay, so that's going to cover, seeing a primary care, any sort of lab work we have done, blood tests, things like that, preventative care, maybe an outpatient surgery, any medical equipment we have around our home, right? You can see the whole list here is going to fall under Part B. And what's nice about Part B here at the bottom is anything the government deems as being preventative, they're going to pay for all of that cost, 100%. So if you get a flu shot, if you get a COVID vaccine, annual physical from your doctor, right? Colonoscopy, all those preventative stuff, they're going to pay for all of it. Anything not considered preventative, though, they're going to only pay for 80% of it, which means that us as Americans, we're on the hook for that 20%. And I often make the joke here, this gentleman's having a grand old time not knowing he's on the hook for 20% of that reconstructive knee surgery he's in there for. But the good news for him and for all of us is there's ways we can plan for that expense. But I want to make the point here that is what is covered under original Medicare. So when you hear the term original Medicare, it only refers to parts A and B, as those are the only 2 parts we get from the federal government. Okay? Part C and Part D isn't mandatory, and you would get those through a private insurer. So when you hear Part C, that's synonymous with the Medicare Advantage plans. And that's the option we have to get really all of our coverage under one roof, right? Under one umbrella. Almost think about Part C like a travel agent, where you would get your rental car, your hotel, and your flight all packaged under one nice, neat umbrella. So that's the way Part C works. And then moving on to Part D, that's going to cover any medication you have. So any prescription drugs that you receive is going to fall under a Part D plan. All right, so those are the four parts of Medicare. And what we're going to do next is we're going to talk about what enrollment looks like. And I think it's even the easiest to start at number 2 here, where we know you're eligible to receive Medicare at age 65, but you can begin receiving your Social Security benefits prior to age 65. So say someone decides to go on Social Security at age 63, okay? If you're already enrolled in that, the government's going to automatically assume that you also need Medicare, and your enrollment is going to be automatic, okay? You don't have to do anything at all. A month or 2 before your 65th birthday month, you're going to receive your Medicare card in the mail, okay? Nice and easy. Now, number 1 is still easy as well if you're not yet taking your Social Security benefits. And what you would do to enroll is go on the Social Security website, which is ssa.gov. Only takes about 10 to 15 minutes to do it, pretty straightforward. And the first way you can do it initially, okay, is going to be dependent on your birthday month, because you have this 7-month window, and that's called your initial enrollment period, or your IEP. So those 7 months are going to include your birthday month, 3 months prior to your birthday month, and then 3 months following your birthday month. So let me give you an example on the screen here of someone whose birthday is May 20th. So the first day that person could actually enroll in Medicare is going to be here on February 1st. And then the last day they would have is all the way down here on August 31st. Okay. So if someone decides to enroll prior to their birthday, say someone, in this example, this person enrolls on March 5th, okay? The benefits would kick in on the first day of their birthday month, meaning you wouldn't have to wait until May 20th or your birthday. The benefits would kick in on May 1st, all right, if you enroll prior to your birthday month. And then if you enroll in or after your birthday month, the benefits kick in the first day of that following month. So say this person enrolled, June 10th, benefits would kick in on July 1st here. So that's the initial enrollment period. The first time you can enroll in Medicare. If you delay or for whatever reason you miss that window, then the way you would enroll in original Medicare would be during the first quarter of the year. So from January 1st to March 31st is when folks can enroll in original Medicare. Okay, some of these slides I can skip through in the essence of time because we covered all of that. So that was enrollment. Next, let's take a look at cost sharing. And I guess what's easy to understand with Medicare is it works much the same as we have it now with group insurance, where we pay monthly premiums. You do that with Medicare, and then you have your co-pays and co-insurance as well. So those work pretty much the same as we have it now with group coverage. So let's dive a little deeper into how Part A works. So what's great about Part A is it is paid up. It is free as long as you have a 10-year work history of paying your FICA taxes. So if you accumulated 40 quarters of work history, okay, because we know when we pay our FICA taxes, some of that goes into Social Security, the other portion goes into Medicare. So as long as we have that work history, then we are considered paid up, and the government will cover all of that. Now, there's a few ways. If you don't have that, there's a few ways you could qualify through a spouse that we're going to talk about next here in the middle, where if you've been married at least 1 year and your spouse is of that eligible Social Security age, they don't have to be taking the benefit. They just need to be of that age, so at least 62. Then you could qualify through a spouse. And then moving down here, believe it or not, you can be divorced and actually still qualify through an ex-spouse as long as you check a few boxes of you'd still need to be single, meaning not yet remarried. You would need to be married at least 10 years, and your ex-spouse needs to, again, be of that eligible Social Security age. So if you check those three boxes, you could qualify through a ex-spouse. And then moving down to the bottom here, in a widow situation, you need to be married at least 9 months prior to date of death and not yet remarried, and you can qualify through a deceased spouse as well. So that's Part A. Next, moving on to premiums with Part B and D. And we're going to table Part C for the moment. Again, those are the Advantage plans. I promise you that's a whole section we're going to tackle in a little bit. But for the time being, we're going to take a look at B and D premiums. And I do want to apologize. Well, we don't have this updated yet. We're going through the process of updating all these numbers for 2025. So we're kind of in that weird period. But the premium this year for folks for Part B is $174.70. Next year, that's going to be, I have it written down there. So that's going up to $185 next year, okay? So it's going to be $185 a month for your Part B premium. And if you are taking your Social Security benefits, then they're going to take that right off the top of your monthly check. You don't have to do anything at all there. If you're not yet taking your Social Security benefits, then you're actually billed on a quarterly basis as opposed to a monthly. You'll be billed quarterly, and you could go right on that Social Security website to set up, an auto easy pay type thing there. Next, I want to talk about something really important that I find a lot of Americans don't know about. It's something called IRMAA. It came out in 2007. That impacts high income earners. I can promise you no one was thrilled when this came out. And basically what this is saying is the more money you make, the more money you're paying for your Part B and your Part D premiums. So the way this would work is, say you have someone enrolling in Medicare this year in 2024, the IRS is going to do a 2-year look back, meaning take a look at your 2022 tax return. We're almost in 2025. So anyone enrolling next year, they're going to take a look at your 2023 tax returns. And what they're going to do is they're going to take a look at your modified adjusted gross household income, and you're going to be paying the $174.70 or the $185. Again, this whole slide, as you can imagine, is going to be different with the 2025 numbers, but conceptually, it's all going to work the same. So just try to bear with me on that. Okay, so let's just take the 2024 numbers so you kind of understand how this works because it's important. So the premium, the 174.70, is going to be for individuals who file joint and make 206,000 or below, or file individually and make 103,000 or below. They're paying the 174.70. Anyone making north of that amount is going to be paying more. So let me give you an example of a joint household who makes 300,000 a year. Okay, they're going to be right, if you can see my mouse, right here in the middle. So they're making 300,000 a year. Well, they're not paying the 174.70. In fact, they're actually paying double that down here. They're paying about $350 a month, and that's each person. Okay, just because they file joint, they don't pay joint. When we talk about Medicare, it's each individual. So each person will be paying $350 a month. I mean, that's double what they might have planned for the 174.70. So the point I'm trying to make here is a lot of Americans don't know about IRMA. You might be paying your premiums and get whacked with this bill in the mail, totally blindsided and say, what in the world is this? It has to do with your income. Now, before we move forward, I do want to let you know that there is an appeal you could file, a few qualified reasons to appeal it. You would get that right on the Social Security website. So that's Form SSA-44. It's only like half a page, really easy to fill out. And what you'd want to show the IRS is a few qualified decreases in income you have, such as maybe someone retired, they reduced your work hours, you're not making as much now, maybe someone got divorced and their ex-spouse was more the breadwinner, or in the widow situation, a deceased spouse is more the breadwinner, right? Things like that, the government would probably grant you the appeal and adjust the IRMA accordingly. Now, the flip side of that to be aware of is some of the reasons the government would probably not grant you the appeal would be if any of you took a large 401k, IRA distribution, maybe you sold beachfront property, sold a boat, right? Things like that, the government would not grant you the appeal. So if you're approaching that, again, remember it's a 2-year look back. If you're approaching that 2-year window that you might want to enroll in Medicare, just be aware of that. Maybe do those things prior to that to just, we're trying to just avoid you paying anything additional that, you don't have to pay because Medicare is expensive enough on its own. We don't need to be paying anything more additional. Before we move on, I would say if someone does get hit with an IRMA, theoretically it wouldn't stick with you forever because, again, the IRS is always doing a 2-year look back. So, say someone sold a boat, odds are they're not selling a boat every single year, and eventually that would just roll off of your tax return. But it's just important to know that does exist and kind of understand how it works and operates there. Okay, so now we're going to talk about the Part D premiums. Again, this is going to cover your drug needs, and you get one of these depending on how many medications you need. Some plans are $0 a month, as you can see here, to well over $100 a month, depending on your individual drug needs there. And the national average is just over $55 a month. Now, the really, I think, important takeaway on this slide is going to be this green box here, where remember at the beginning I said that Part D isn't mandatory. And that is true, but it doesn't mean Medicare doesn't track your enrollment in a Part D plan. In fact, if you enroll in a Part B plan, okay, and then at a later date enroll in a Part D plan, there's actually a penalty for that. Okay, again, a lot of Americans barely understand what's going on with Medicare, let alone some of these penalties. So I want to talk to you about how the penalty works. The government will say it's 1% each month in the gap that you were enrolled in the Part B plan and then later enrolled in the Part D plan. So I want to give you an example of that so you understand, because I understand this is very confusing to Americans. So let's say someone is 65, healthy as can be, enrolls in Medicare, Part B, doesn't have any drug needs. Say, why in the world would I enroll in the Part D plan? I don't take any medication. I think that seems logical. We'd all think along the same thought process there. Now let's fast forward 5 years. Same person, 70. They become sick and now they have drug needs. Okay. And they say, hey, I need one of those Part D plans to cover my drugs. Well, the government's going to say, okay, it's been 5 years and we know it's 1% each month. So if we take 12 months times 5, that's 60% of a penalty that person would now have tacked on top of their Part D premium. And it never goes away. The government hits you with one of these penalties, very unforgiving, unfortunately. So maybe some advice for all of you is when you enroll in Medicare, hopefully we don't have any drug needs, but just be aware this exists. Maybe find the absolute cheapest one that you can. the important thing is that you're enrolled and you have the coverage. Keep in mind now, during the annual election period, from October 15th to December 7th, you can shop a new plan if need be. But the important thing is that you're in the plan. Okay. So just really, again, important to know that that penalty does exist. So what we're looking at this slide, this looks a lot like the Part B slide. This is Part D. And the point we're trying to make here is that IRMA I talked about comes into play as well. We'll look at that same couple making $300,000 a year. Each person will be paying an additional, $33.30 a month. I guess the good news here is that if you do file that appeal for Part B and they approve it, you don't have to do a second one for Part D. They're going to automatically approve it for Part D. Flip side's also true where if they deny you Part B, they're going to automatically deny you Part D as well. So they work hand in hand that way. So those are the premiums. Next, let's take a look at some of the cost sharing we have. And, again, this is what the government's going to cover us for as Americans. Again, Part A is paid up as long as we have those work history. We don't have to pay anything monthly. But if we do have an overnight stay, say in January, in the Boston area is icy and I slip on some ice and I have an overnight stay, this year I would be hit with my deductible of $1,632. Next year that's going up to $1,676. Okay, and then just bear with me for this example. Again, I realize for a broken knee you wouldn't have this long of a hospital stay, but bear with me. So I'm in the hospital. Okay, for 60 days I'm fine. Now on day 61, a daily copay kicks in, and that's going to be $408 a day. 30 days after that, on day 91, it doubles to $816 a day. Then after day 150, we would be paying all of the cost in the walls of the hospital. Again, there's ways we can plan for this expense, but this is what the government's going to cover for us. And then moving down below here, they're going to pay for the first 3 pints of blood. Hopefully they have it in the hospital. If they don't and have to transport it, guess what? We're paying that expense as well. And they're going to pay for 20 days in a skilled nursing facility. Then you'll see on day 21 to day 100. After day 100, we're paying everything. But from days 21 to 100, we'll be paying $204 a day in a skilled nursing facility. Okay. So that's cost sharing for Part A. And then for Part B, the deductible this year is $240. Next year, that's going to be going up to $257. As you can imagine, we know healthcare never seems to go down, always seems to go up. Now, I want to bring you back to the beginning of the presentation where I said anything considered preventative, the government's going to pay for 100% of that cost. So we know that's true. But then we also know that anything they don't deem as being preventative, they're going to pick up 80%, which means that we're on the hook for that 20% coinsurance. And that is so important to know. That is uncapped. Okay, we would be paying 20% forever. Okay, so think about if someone had cancer and needs chemotherapy, how gigantic even 20% of that health bill would be. If someone didn't plan for that or got blindsided, that could wipe away someone's retirement savings, which we definitely don't want to happen. So that brings us to the next portion of the presentation of how can we cover those gaps that exist in original Medicare. And there's 2 ways we can do it. We're going to talk about both. And the first one is getting a Medigap plan or a Medicare supplement plan. Those are synonymous. And that's the more expensive option. But with that monthly, more additional expense, you get a lot more bang for your buck and a lot less out-of-pocket cost sharing after that. The other option you do have is getting a Medicare Advantage plan, which is certainly the cheaper option. But also with this, be aware that there's a potential for a higher out-of-pocket cost sharing as well. So pros and cons to each of these, but we're gonna talk about those right now. And what we're gonna do on this page is talk about Medigap. So the way Medigap works is we're not dealing with doctor networks. You can see here over 1 million providers available. So really any physician you want to go seek, you can go ahead and see them. Medigap, because we're not dealing with networks, is great for nationwide travel. So a lot of us here in the Northeast like to get out of freezing cold winters, go to sunny Florida, what have you. Your Medigap plan would travel with you as well. And then moving down to the bottom here, they're pretty easy to understand. There's only 10 Medigap plans, and each plan, okay, here's our 10 plans. Each plan, the coverage is standardized, meaning say I like Plan G, I think that's best for me. Well, it doesn't matter if I get Plan G from, Blue Cross, United Health, Aetna, what have you. I'm going to want to shop who's going to give it to me at the cheapest rate. Okay, the coverage is going to be standardized and stay the same. And why these are so popular? Because, they're meant to pick up the gap, hence the name, or supplement what original Medicare doesn't cover. So let's go back to that broken knee example I gave you with my Part A deductible. If you can see it right here. Well, you can see all the different, 100% here. And my Plan G they're going to pay for all of that cost. I'm not paying that, $1,600 for my overnight stay. My Medigap plan's paying that. And as you can imagine, all the different hundreds and 50%, 75s, all going to, pay for different things that original Medicare doesn't cover. So that's why this option is very, very popular for folks as well. So what I want to do on this slide is I want to put it all together because I know so far I've been throwing, a lot of dollar amounts at you. So let's see what it might cost you on a monthly basis to kind of gauge it a little bit here. So we'll say we're, paid up for Part A, so that doesn't cost us anything. And then for this example, we'll take IRMA out of it and say the Part B premium is just about $175. And the Part D for prescription medication, we'll say is about $55 a month. And then Plan G is quoted at about $100 a month for the folks out of Texas who creates this presentation that I'm delivering today with John Hancock. That's their quote. I would say in Massachusetts, that's going to be about maybe $250, $300. Anyone on today's call from New York, you folks have the highest premiums arguably in the country. We're surely going to talk about why that is. Again, this is the more expensive option, but just say for, $450 to $500 a month, or more than that, this would be a really, nice kind of outstanding form of healthcare coverage to get with this. So, again, kind of gauge what it might cost you on a monthly basis. Now, moving on to this slide, this is a very important slide to talk about, and it's because when you enroll in Medicare Part B, the clock begins to tick on this one-time 6-month window we have to enroll in a Medigap plan without any health questions at all. So if someone has Parkinson's, if someone has cancer and needs chemotherapy, they're going to absolutely need a Medigap plan to help pay for those costs. And as long as they do so within 6 months of enrolling in a Part B plan, there's no health questions, so they can get any Medigap plan if they want. It doesn't mean you can't get a Medigap plan after that 6-month window, but what it means here on the right is now we're going to have to go through underwriting, which means the insurance company is going to do, a 2 to 5 year look back on someone's health history. And we know if they have, health concerns, underlying health concerns, there's a really good probability that we're not going to get that Medigap coverage that we want. So really important to know that one-time 6-month window that most of the United States follows. Okay, 38 states follow that more strict federal guideline. The good news is that if anyone on today's call lives in any of these 12 states, at the state level, they've actually implemented a more lenient interpretation of that. I just referenced New York. Anyone on today's call out of New York, you folks, throw what I just said out the window. You have open enrollment for Medigap all year long. Anytime you want a Medigap plan, you can go ahead and get one. Caveat to that is it's the most expensive in the country as a result of that. Okay, anyone Massachusetts where I live, folks, every February, March can swap Medigap plans with no health questions. Okay, so again, you're going to want to research if you live in any of these 12 states, the more lenient interpretation of that more strict federal guideline I just said. Okay. Again, we'll skip some of these slides, talk to you about what you need to know here. Okay, wrapping up Medigap. You'd want to ask your medical provider, do you accept original Medicare? If they do, they're going to automatically accept Medigap. We know that we talked about the plans being standardized, meaning you'd want to just shop which insurance provider is going to give you the coverage at the cheapest rate. Then really important to know is that they're guaranteed renewable, meaning if you have a Medigap plan and you become sick, the insurance company cannot deny you re-upping that plan. They must guarantee that you can renew that coverage as well. And then moving down to the bottom, is important to know that the benefits don't change annually. The premium might change, the premium might go up, but what's covered does not change annually. So these would be more of a set it and forget it option for you. And why that's important to know is because in a short time, we're going to talk about the Advantage plans, and those benefits could change annually. There's more homework involved with those. With the Medigap, once you get your coverage, you're good to go. But then also keep in mind, unlike the Advantage plans that oftentimes do have the drug component, the Medigap plans don't. So that means you're going to need to add a standalone Part D plan to make sure that your prescription medication is covered. I often laugh at this slide because as if Medicare isn't confusing enough, they decided to make Part D have a four-part kind of pricing model involved into it. So I'm gonna quickly go through this slide because in a few months, in a few weeks, I should say, in 2025, a lot of this is going to change. So, but just kind of bear with me. So first, you'd pay your deductible. After you move that, you move into the initial coverage period, what most Americans would live in. Then, if your medical or your prescription expenses exceed a certain dollar amount, we're going to talk about in the next slide, you'd move in the coverage gap or the donut hole. You might hear this term in the news often these days. I'm going to tell you why on the next slide. And then we can skip catastrophic coverage number 4 here because due to the Inflation Reduction Act, they actually did away with that catastrophic coverage this year. So let me give you an example. The deductible this year for Part D is $545. Next year, that's going up to $590. Then what would happen is in the initial coverage, us and our insurance provider would pay, co-pays, co-insurance for our medication until the total expenses exceeds just over $5,000. At that point, we'd move into what's called the coverage gap. That's when you're paying up to 25% out of pocket for your medication until your out-of-pocket spending reaches $8,000, right? Think how expensive this is. This is just talking about Part D. And then we talked about the catastrophic coverage. Once you exceed $8,000, you're done. The insurance company is going to pay for all of it. Now, due to the Inflation Reduction Act that President Biden passed August of 22, I'm going to draw your attention here, 2025. So what's going to happen next year is that $8,000 I just referenced is gone. There's going to be a $2,000 annual cap on your Part D spending, okay, which is great. Big win for us as Americans. And really, just to quickly hit on some of these things you need to know is some of the vaccines that, like shingles, that actually fell through the cracks of Part B, they put that under Part D. They put a cap on how much the insurance companies can increase a premium every single year. We just talked about next year, a $2,000 annual cap. And then the year after that, so 2026 to 2031. So in those 5 years, government's going to renegotiate about 10 drugs a year with the big pharma companies, renegotiate pricing, make it more affordable with some popular drugs people on Medicare depend on, like, arthritis, cholesterol, heart medication, cancer, things like that. Just, again, this whole Inflation Reduction Act, a lot of Americans don't know they actually put a lot of great Part D parts into it to really make it more affordable for folks. Okay, I said there's 2 options to pick up the gap. We're going to close the book on the first option. That's the Medigap route. Now we're going to open the book on the other option you have, and we're going to talk about the Medicare Advantage plans. So the way Medicare Advantage plans work is now we're dealing with doctor networks. So these could work in an HMO or a PPO type format, right? You need to live in the walls of that network. Oftentimes you can't go outside of the network except in emergency type situations. So that's the way the Advantage plans work. Now, moving into the middle here, Americans love these because there's no health question. So as long as you get one now in that annual election period in the fall, it takes place every fall, you can get an Advantage plan. So that's the reason why we see so many commercials on TV is because we're in that annual election period right now. And then moving on to this blue box here, like I said, they're easy to get. Americans like that. They throw in, a lot of times they throw in dental or hearing, vision plans, sometimes gym memberships, right? All these kind of things they're going to package nice and neat. Again, these are the travel agent, that analogy I made. That's the way the Advantage plans work. The flip side to that, though, to be aware of is that sometimes physicians don't love Advantage plans. And one of the reasons for that is because they consider them a hassle, that you need prior authorizations, okay? Let's go back to my broken knee example, and the doctor says, hey, I want to take a closer look at that. I want you to go get an MRI so we can do that. Well, I can't just go get that MRI. I need to work with my Advantage plan provider to make sure that they're going to pay for it. They may pay for it. They may not pay for it. In the Wall Street Journal last week, there was another piece coming out about some of the Advantage plans denying, paying for some of the medical benefits people depend on. So sometimes you see these in the headlines of them not paying for some of the things that Americans need them to pay for. So maybe that's another story for another time. It's just something to be aware of, that prior authorization is something necessary with the Advantage plans. But again, they have lower premiums, certainly the cheaper option than the Medicare plans. And what we're going to do on this slide is talk about what an Advantage plan might look like, kind of like, pay as you go for type thing. So a plan might look something like this, like maybe $20 to see your primary care, maybe $50 for a specialist, right? Things like that you can see. But the main takeaway on this slide I have for all of you is this thing here called an OOP max. And what that stands for is an out-of-pocket max. And this is the stuff that they're not going to tell you on the TV commercials, right? Joe Namath is going to talk to you about how wonderful his Advantage plan is. He's not going to tell you what an OOP max is. So really important to know that these do exist in the Advantage plans. So the max limit this year is $8,850, okay? This goes up every single year. I haven't seen next year. I'm going to assume it's going to be in the $9,000 range. So what that means, though, is for some of these big ticket items like chemotherapy, someone that has kidney failure, like dialysis, you might be getting a medical bill for up to 20% of that healthcare cost. And you didn't know about that because you thought the Advantage plans was cheap and it's great and it's affordable and all these things. Yes, it is when you're healthy. If you become sick, important to know that that out-of-pocket max does exist. Now, the other side of that is not every single plan, not every single Advantage plan has an OOP of that max. You might find one that has one for like $6,000, $5,000, what have you. The key takeaway is just know the Advantage plans do have that out-of-pocket max that if someone didn't plan for it, they might get blindsided with a steep medical bill. Okay. What we're going to talk about in this blue box is some 7 and 10. What does that mean? Well, that means last year in 2023, 7 and 10 or 70% of Advantage plans had a $0 premium, which sounds awesome. I mean, that sounds like free healthcare, sign us all up for that. But as we begin to think about that, I'm not sure if it passes the smell test, and it kind of begs the question, a Medicare Advantage plan smoke and mirrors, a Medicare Advantage plan is bad. And I'm not certainly here to not say that they're bad. I'm here to say that they're often misunderstood. Really important in today's call for us to just be educated as to how the Advantage plans work, so then when our time comes to enroll in Medicare, we can make the most educated decision for us. Because as you go through this, you're going to see it's certainly not one size fits all. It's very case by case basis. So as long as we kind of understand how it all works, it just makes that decision we have to make easier. So just be aware that some of these unexpected, again, you can see up to 20% of some of these unexpected costs that we might have if we go with the Advantage plan route. So some tips we have for anyone who does want to go that route, as you can see here. Number one, simply build a rainy day fund like you would for any sort of unexpected cost, because the Advantage plans are going to be great when you're healthy. You're paying zero premium, all that. But just know if you become sick, then you might be paying a lot more out of pocket than you anticipated for. Then sometimes at that point, if you're sick, and they're trying to go to a Medigap plan, then you're going to have to go through underwriting. Then we might not get the coverage we want, so we might be, kind of stuck with an Advantage plan. So we just want to build a rainy day fund up for any sort of unexpected costs that we impose. Hopefully we never dip into that, but you're going to be happy if you do need it. Number two, how and when you enroll matters, meaning you need to enroll in the fall right now during the annual election period. Number three would be advice for anyone who likes to travel. Remember that we're dealing with doctor networks with the Advantage plan, so maybe look for more of a national carrier to make that network bigger, so you're not so handcuffed to a smaller network there. And then number four, really important, like I mentioned earlier in the Medigap portion, is don't forget to reevaluate your plan every single fall, because what's going to come out in September is going to be something here called an annual notice of change. And what's going to happen in that annual notice of change is they're going to outline the following year any benefits that they might add to your Advantage plan, or any benefits that they are taking away from that plan. They're no longer covering in that plan. So we get that in September. Then you have the fall to shop a different Advantage plan that now has the coverage that you need, because think about someone who didn't bother to read that annual notice of change, and there's a medication that used to be covered that's not, or a procedure, right? Something like that, and they didn't bother to read it. Well, they'd be in a tough spot. I mean, they'd be paying out of pocket that whole year until the next, fall comes around when they can get a plan for the following year. So, really just important to know how really differently, and this brings us to Medicare misstep number 2, just how differently the Advantage plans work from the Medigap plan. We talked about the Medigap plans being more set it and forget it. Then we talked about the Advantage plans. We're just going to need to do more research and homework as well to make sure that we always have the coverage in place that we need. Okay, so this brings us to our last topic today, really important one, and that is working past age 65. Now, I think the easiest way to cover this topic is by picturing an imaginary line in the sand the government draws at, do you get your coverage from a large employer or a small employer? Meaning, do you get your coverage from a company that has 20 or more employees, which is large, or less than 20 employees, which is small? And why that's so important to know, because it really matters. So let's talk about large employer, okay? Excuse me. So if you get your coverage from a large employer, meaning one that has 20 or more employees, the group coverage you have is considered primary, and the Medicare coverage would be considered secondary. The bottom line to what I just said is you have the option at age 65 to delay enrolling in Medicare, and there's no penalty for doing so. Okay, you have that option when you work for a large employer. In fact, sometimes you'll see, folks do a cost comparison, right? Because if you're eligible at 65, people ask me all the time, what should I do? I'd say, well, every company's group coverage is different. So you're going to need to do a little cost comparison, see if group coverage makes more sense for you, or would it be cheaper to go on Medicare, right? For everyone, that's going to be different. But sometimes you see folks enroll in Medicare Part A only because they'll say, hey, I'm paid up, it's free. And why would I not have a secondary safety net in place in case I do have an inpatient hospital stay? And you can certainly do that. Just be aware that once you enroll in Medicare, you can no longer make health savings account, HSA contributions, because unfortunately there's a tax penalty for that. Some Americans might not contribute to an HSA, might not care, which is fine. Other Americans might want to pump as much into that as they can so they can then use that money when they enroll in Medicare. For everyone, it's different. Just know that you do have that option when you work for a large employer. Now, moving down to a small employer, now the government flips everything I just said. Now they're saying, well, Medicare is primary. You're on our watch. The group coverage that you have is secondary. You can still keep the group coverage. A lot of small employers have great group coverage, but because Medicare is primary, then you would need to enroll for parts A, B, and D at age 65 to avoid any penalties you might have where if you delay doing that at age 65. So I want to talk to you about that penalty I just said, because earlier we talked about the Part D penalty. Most Americans don't know this exists as well. So the way the way the Part B penalty would work is the government's going to say it's 10% each year that you should have enrolled in a Part B plan and you did not. So I'll give you an example of, let's say we have an electrician who works for a small employer with, there's 12 electricians they work for, a small employer. And at age 65, he stays on the group coverage. At age 67, he retires and he enrolls in Medicare. The government's going to say, okay, it's been you should have enrolled at 65, you didn't. It's been 2 years. So you now have a 20%, because it's 10% each year, right? You now have a 20% penalty tacked on top of your Part B premium that never goes away. Sticks with that person forever, unfortunately. So just really important to know, right? We get very confused with this because a lot of times you'll see friends and family, they'll say, no, you need to enroll at 65. They'll say, no, absolutely, you can delay enrolling, whatever works for you. You can see they both might be right, depending on your situation of where do you get your coverage, large or small. Really important to know that. Okay. All right. Well, this brings us to a high-level overview of everything we really talked about today. So we'll do a high-level recap of that. We talked about the 4 parts of Medicare, okay, where we know parts A and B are what's considered original Medicare, the only 2 parts we get through Social Security, where A is going to be our inpatient, right, and B is our outpatient coverage. And then we talked about parts C and D being options we have through a private insurer, where we know C is synonymous with a Medicare Advantage plan. And that's the option we have of getting all of our coverage through a private insurer. Remember the travel agent, okay? And then Part D would be all of our medication, drug coverage there. This slide, we're gonna cover that gap that we talked about, the two options you have, and we'll take the middle first. So first option you have is enrolling in original Medicare A and B, adding a Medigap plan or supplement plan, those are synonymous, and then adding a Part D plan for drug coverage. We talked about this being the more expensive option, okay, certainly more expensive, but then as a result of that, you have little to no out-of-pocket costs after that because you're really paying up for that coverage. And then we're not dealing with doctor networks, so really any medical professional you want to go seek your coverage from, you can go ahead and see that person as well. Another option we have going down to the bottom is certainly the cheaper option is by getting a Medicare Advantage plan. We know these are definitely cheaper, lower premiums, but now we're dealing with doctor networks. And also there's that potential for more higher cost sharing, more unexpected out-of-pocket costs as well. And then moving to the top here, I'd certainly discourage anyone from only having original Medicare without any sort of supplement at all, because we know there's no cap on that 20% that we're on the hook for. Someone gets really sick and that 20% could just wipe away someone's retirement savings. We don't want that. So we're going to need to make sure we have some sort of plan in place for that. And then we just talked about this, but we'll do it again because it's important, and that's working past age 65. And we get our coverage from a company, a large employer, remember, company has more than 20 employees, then yes, you can delay enrolling in Medicare at age 65, and there's no penalty for doing that. But we know if we get our coverage from a small employer, one with less than 20 employees, then we must enroll at age 65 for parts A, B, and D to delay enrolling and potentially getting penalties later in life if we get our coverage through a small employer. Now, before I pass it over to Rita for any questions you might have for me, I do want to draw your attention to some resources on this page. This is the Social Security website. So SSA.gov, that is where you will go to enroll in Medicare. Also, remember that IRMA appeal form, that SSA 44? That's right on there as well. You'd find all of that through that website. And then I do like to give a shout out to Boomer Benefits. They are the company John Hancock partners with to present this material today. We are not affiliated with them. This is, they do Medicare all day, every day. So anytime someone asks me a question or I want to do a little more research on Medicare, I go to their website, there's blogs, all types of stuff like that, because I feel like anytime I do a Google search and I type in the word Medicare, it's all this, Medicare Advantage, people trying to sell me stuff, all of that happens. So point being, there's many credible sources. They would be one that you could go to. Okay, so with that, thanks everyone so much for attending. Hopefully you found this informative. This brings us to our Q&A portion of the presentation. And Rita, I'm going to pass it over to you for any questions that people might have for us.
Thank you so much.